Hello and good morning, everyone. This is my pleasure, Dr. Subhash Banerjee, to invite you all again to our next monthly webcast from the XLPAD Forum. It is my great pleasure to once again invite my esteemed colleague from Pakistan, Karachi, Dr. Abdul Basit, who is the director of the Basit Institute of Diabetology and Endocrinology. Dr. Basit's role and contributions in the field of diabetes is illustrious. His model is not only followed, not only in Pakistan, which has led to significant success, but also in many other countries in South Asia. And I'm looking forward to hear the second part of his lecture being dedicated to the management of diabetic foot as an outpatient treatment. So take it away, Dr. Basit, and we look forward to hearing from you. And once again, thank you for joining in at this late hour of your day.
Thank you, Subhash. Thank you for your kind words and introduction. I hope that today we are able to cover in the next 20-25 minutes about the diabetic foot management as outpatient level. The first question I like to put to myself, to my team, and to the audience is, why are we so concerned about diabetic foot care as such? And the reason we can see on the slide is the high mortality, and these are the mortality results. 70% of people who undergo a lower extremity amputation because of diabetic foot, they die within 5 years of amputation. So if you look around, amputation 68% is between colorectal cancers and lung cancers. Anything between them is the 5-year mortality. So this is why we are so concerned about diabetic foot as such. And in Pakistan, we having 7.1 million diabetics. We had 4.4 million people with foot ulcers. And unfortunately, till we started, we had no foot clinic, no diabetes educator, and no qualified podiatrist in Pakistan. So first thing we did, in fact quite a few years now, is found out what's happening with diabetic foot in Pakistan. So those people coming to us, day one we had some of the data that was published that male having more ulcers than female. In fact, this is a universal fact. Total unawareness about foot care. 50% of our patients had previous history of foot ulcer. 70% had poor diabetes control. So what are the methods for looking for diabetic foot? First is looking for or screening for peripheral neuropathy. We do not need, by this slide I want to emphasize, we do not need hi-fi gadgetry for looking for sensory neuropathy. A simple monofilament and a tuning fork, and if possible or available, a neurothesiometer may be the simple gadgetry needed for neuropathy. The main, I would say, the reason for diabetic foot is still sensory neuropathy, the painless nature of the diabetic foot. And you can see some of these slides, like this lady had the nail gone pairs and pairs. This is the x-ray of somebody else having a nail, needle, in fact, the sewing needle inside. And this needle, I suppose I'll make it more clearer, gone through and through. So the painless nature of diabetic foot disease is the main, you can call hallmark, or the main reason for diabetic foot. Then on top of it, you get motor neuropathy, atrophy of intrinsic muscles, flexion deformities, increased pressures, calluses development, and this causes ulceration. So in fact, on top of sensory neuropathy, or along with it, is the motor neuropathy, which worsens the situation for diabetic foot. And so if I remind here that ulceration does not occur spontaneously, rather it's a combination of causation factors, and this is important to understand when we talk of management of diabetic foot, especially prevention of diabetic foot. So again, these are the component causes and the causal pathway. Neuropathy sets in, and then neuropathy with deformity, and in fact then comes a trauma-informed environmental agent, i.e. like in this case, if the pressure is not relieved, he or she will develop ulcer, which he has done. and then the ulceration. So in fact, there are many components, and it's not as simple a pathology as we usually think of. Coming directly to management strategies, it has to be multi-pronged. So metabolic control, antibiotics, role of podiatry, offloading devices, and surgical management. As I said earlier to Subhash, that I will be covering management of peripheral artery disease separately in the next lecture of the series. In fact, that's the next lecture. So it means that today I'll be referring to these 5 items of management. As regards metabolic control, the first is to have a good glycemic control. Now, I have written in front insulin in most cases. This is our experience in Pakistan. We share with other colleagues that even if patient has got good glycemic control with oral medicines, this is one of the best windows we find to introduce people on insulin. As people with diabetes are living longer, as the general population is aging, people tend to live longer with diabetes, 20, 25, 30 years. They eventually need insulin. Many people in our part of the world have reluctance to go on insulin for one reason or the other. But the 2 good windows for introducing insulin, one is diabetic foot and one is gestational diabetes or diabetes in pregnancy. That is the time when people want to save their foot or to save their baby in utero. So insulin is introduced earlier in 2 cases. Tight blood pressure control, improved lipid profile, cessation of smoking, consideration of antiplatelet therapy. I have question mark vasodilators here. This is my old slide. Again, covering the PAD, we can discuss vasodilators in that lecture particularly. Foot infection. About 85% of the major amputations in patients with diabetes begin with foot ulcers, and infection is usually involved in the final common pathway. This is just a reminder, simple clinical classification of diabetic foot infection. Grade 1 is wound without purulence or other evidence of inflammation. Mild is 2, which is more than purulence, erythema, pain, tenderness, warmth or induction, any 2 of these factors. Any cellulitis or erythema extending to more than 2 centimeter around the ulcer. In fact, it's less than 2 centimeter around the ulcer. When it's more than 2 centimeter, we take it as grade 3 infection who is systemically well patient, otherwise metabolically stable, but have a cellulitis extending to more than 2 centimeters, as you can see in the photograph. Lymphangitis spread beyond the fascia, deep tissue, etc. And severe is patients come in landing with systemic effects, toxicity, in sepsis, in SIRS, in fact, multi-system failures. I'll discuss the inpatient management in the next lecture, and we'll cover that hopefully. So infections we see much different from what will be seen in your part of the world. We see severe infections, those which usually people who are not used to seeing diabetic foot would not like to see. We call them dirty pictures, but this is what we have to see on almost a daily basis. Severe infections of all kinds in diabetic foot, landing late. This is our paper to be sent for publication, that majority of them are polymicrobial infections if you do cultures and sensitivities. In fact, we do not do them routinely, especially as outpatients. We cover with antibiotics, get good results. We only do swabs if a ulcer is resistant to our normal treatment SOPs. And as I said that because we are a tertiary care center, people come late to us. They have been through their family practitioners, family physicians, GPs, etc. at all primary and secondary care levels, had antibiotics. So it's multi-drug resistant when they land with us. So for antibiotics, our general rule is good infection control, early introduction of antibiotics. There ought to be broad spectrum, combination therapy, and for longer duration. Moving on to podiatry, what is known as podiatry in the Western world, we cannot afford those podiatrists, so we call them here diabetic foot care assistants. We train them ourselves. They do a 6 weeks course with us. They are not trained healthcare professionals. They are only what we call as dressers who are used to doing simple dressings with doctors. We take them, or OT technicians, etc. We train them into podiatry and supervise podiatry under physicians and surgeons. They do. Now this is the key to healing. If this is the ulcer with a dry skin, a scab and a callus, you do sharp debridement, make the patient bleed basically. If you are able to do it successfully, then you ensure good healing. So this is where the role of diabetic foot care assistants or podiatry is: removal of callus to ensure that it heals. If a surgeon has removed the toe, then provision of orthosis, etc. The other important aspect is offloading devices. Now these offloading devices are low cost. They have been developed by us ourselves. This is the footwear device. So this is a footwear. We take the insole, we make a cut here so that the pressure is offloaded and an ulcer heals. These are healing sandals, very low cost. These are modified rocker bottom so that patient can walk on it. This is bowler iron, which is used for heel ulcers. This is a heel ulcer, and we use them on the heels. So this ulcer, which takes ages for heal, in fact heals within 6 weeks. This is a Scotch cast, which is a bit more posh, removable in fact, for those who can afford to have a costlier one. This is a Scotch cast. Again, all are locally developed. And we did our own study to find out that the healing rate, in fact, healing rate is good for all kinds of offloading devices. The cost is tremendously different. So we usually go for modified footwear sandals or for plaster of Paris cast, rarely for those who can afford for the Scotch cast, as the healing time is same. But offloading device is something tremendously needed for neuropathic ulcers. This is our own amputation rate in Bakai Institute of Diabetes in the last 16-17 years. Our amputation rate has reduced by 75%. We then have been able to develop a network, Pan Pakistan, of 115 foot clinics, where the amputation rate is half. As I covered this in my previous lecture, I am not taking too much of time on it. We intend to develop some 1,700 such diabetic foot clinics, Pan Pakistan, with the fullness of time. This is my latest workshop we conducted in May in The Hague in Holland. This meeting of diabetic foot takes place every 4 years, where consensus guidelines for diabetic foot management are being developed. And my topic here was development of footwear. So we do not have no special footwear manufacturing in Pakistan yet. We are in the process of developing it, which will be good for general diabetic patients without having developed a foot ulcer, and we call it like preventive footwear. We are trying to avoid giving a special name or make it specialized or have a franchise manufacturer to keep its cost low and patient friendly for Pan Pakistan. Sorry, I'll end up with 3 cases just to give you a flavor of what we see as outpatients and deal with. This is a 36-year-old male type 1 diabetic with peripheral neuropathy. He got this burnt from a motorcycle exhaust cylinder. We call them silencer, the cylinder which is very hot. And this patient with chappals and neuropathy had his foot on the silencer. got it burnt by the time he reached the destination. Sharp debridement was done for the devitalized tissues, broad spectrum antibiotic, and home podiatry service was provided. And it took 4 weeks, but the patient wound healed completely. The other was a 45-year-old lady, type 2 diabetic for 10 years, presented with non-healing neuropathic wound. This, as you can see, I'm sure it will have all the bone involved, etc. In fact, it was started with callus formation. So again, we cannot neglect callus. This is where our podiatrist role comes in. In her case, toe amputation was advised at another center. We took the charge. Extensive debridement was done, and this is what we call as, this is a good evidence that a track is there through and through. Management is in fact easy in such cases with extensive debridement from both ends, broad spectrum antibiotics, home podiatry. For 8 weeks the management took place, but the wound was healed luckily. So again, we saved an amputation. This is another 42-year-old housewife, type 2 diabetic, insulin treated, presented with non-healing ulcer of right big toe for 2 months. Initially started with by the footwear, but in fact this is all iatrogenic, if I dare to say, i.e. went to the local doctors, kept putting on dressings, kept giving her antibiotic courses half-heartedly or half dosage or for shorter duration, etc. Lend it to us. Now this is gross osteomyelitis. This is sausaging of the toe. In the past we would have gone for her toe amputation. X-ray shows in fact completely dissoluted bones. So amputation was advised, but what we did is started debridement. In fact, what we have developed a technology, we open the toe from here, remove the dead necrotic bone out, and once the necrotic bone is out, osteomyelitis in fact heals, because remember, this is not hematogenous osteomyelitis, this is local osteomyelitis characteristic of diabetic neuropathic feet. So broad spectrum antibiotics, sharp debridement, you save the toe amputation. So these are the 3 cases I just showed to the audience to generate the question and answer session. 2 months it took, but it was healed. So I finally finish off as I committed in 20 minutes or so by acknowledging my team, and I say thank you to the audience, and I expect a good question and answer session. Thank you all for your attention.
Hi. So
Hi.
So first of all, thank you for taking us through. I'm sorry I lost my connection for a few minutes. Last part.
Apologize. Right.
I appreciate very much for taking the time to go through this. And I also want to tell the audience that your efforts are purely indigenous, and all these prostheses that you have developed have been locally developed and with using your local resources. So I'm sure this is exactly something I think many other countries around South Asia and other places in the developing world are trying to emulate. So if you can take us through, how is your program centrally funded by your government, or this is a completely non-profit organization? How is the structure of this organization currently maintained in your own country?
Right. Bakai Institute of Diabetes Endocrine is part of a private medical university, which is Bakai Medical University. The university has been supporting us and our activities for the last 18 years or so since we were established. Our good part is that we are completely autonomous. So the university has given us free hand that whatever we earn, we shall spend on our own research and academic development, for which we are very grateful to the university hierarchy. Unfortunately, at present, we do not have very good public support or government support, you can call it. So the funds we generate are usually through our own through our own resources. For the first National Diabetes and Diabetic Foot Program, we are very grateful to the World Diabetes Foundation, WDF, based in Denmark. They supported us for that program. And through that program, we are lucky to develop an infrastructure on which we can now expand. So 115 foot clinics establishment, training of the staff, etc. was through their fund and resources. And now, as I mentioned, we are heading towards, inshallah, establishing some 1,700 clinics. But that is through our own collaborations with people in corporate sector and colleagues who are willing to support.
That's fantastic. This is awesome. And the final question, how is there any interaction between your institution, other academic institutions in your own country or across the South Asia that you currently collaborate with, which could be brought into our XLPAD network?
Right. In fact, I deleted those slides for the safety of the time. We show 3 slides in which we show our international collaborators, then the national collaborators, and then those who belong to our own network. In fact, we have got an advisory board for the care of diabetes, linking 12 teaching hospitals of Pakistan. And very soon we are going to get digitally linked as well. 3 of us are already linked, Karachi, Lahore and Islamabad. And as you suggested, for the next lecture, inshallah, we'll most likely have them on board as well. So yes, we have got very good national collaborations. We are very closely linked with Diabetic Association Pakistan, Pakistan Endocrine Society, the Family Physician Society, that is for Pakistan, National Diabetes Educators Association. And for internationally, we are very linked with the IDF, MENA region. In fact, I happen to be the chairperson for the diabetic foot group in the MENA region. Colleagues in India, Sri Lanka, Bangladesh are very closely linked with us. So we have got a very good, alhamdulillah, acceptability and collaboration. And if you feel like expanding what we can call as XLPAD registry, and you like to have names and collaborations in any of these international centers, we'll be more than happy to link you with those centers.
Thank you very much, Dr. Basit. Thank you so much. I think the main focus of our initiative is to bring information that currently exists at your center and make this much more international and learn from this experience and hopefully share this experience with many other institutions. So I would greatly appreciate in your next webcast if you could invite your own colleagues around the country and also extend an invitation from on my behalf to other centers that you collaborate with internationally. I would greatly appreciate that. So once again, thank you for joining us, and we end our webcast today. If there are any questions, you will see the presentation on xlpad.org, and also it will be posted online and also on social media. Thank you, Dr. Basit, for taking the time, and we look forward to speaking with you once again in the very near future.
Thank you, Dr. Banerjee. Thank you, Atif.
Thank you,
Thank you so much.
Thank you so much. Thank you.
Pleasure.
Thank you very much. Bye-bye.
Bye-bye.